Thank you again, everyone, for joining. My name is Kelsey Goforth, and I'm DWDC's Director of Programs. And today I'm joined by my colleagues, Kat Martins and Amanda Coventry-Berridge. Before we begin today, I want to acknowledge that while we are meeting virtually, the land Dying with Dignity Canada is the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples, and is now home to many diverse First Nations, Indigenous, Inuit, and Métis peoples. We also acknowledge that Toronto is covered by Treaty 13 with the Mississaugas of the Credit, and we invite and encourage you to do your own research regarding the various treaties, in particular the land in which you're on while meeting with us today. I'm thrilled to welcome you today to another session of Your Healthcare Team. And this is a series where we provide you with information on the roles and responsibilities of the care providers that make up your healthcare team. Today, our session will focus on community paramedics and how they support patients and their families. Before I welcome our speakers, though, I do have a few housekeeping items to go over. Everyone who's joining us today is muted. However, there's going to be opportunities to submit your questions. So to do that, please type your question into the question bar on the Zoom side panel, and we'll read it out for you at the end. We do have a lot of folks joining us today, and we want to try to get to as many questions as we can. So please do try to keep it as concise and clear as possible. If we aren't able to get to your question today, you're welcome to email us at support@dyingwithdignity.ca, and we will follow up with you. And if you have any questions that are more personal in nature, we're happy to follow up with you directly as well. Just email us at support@dyingwithdignity.ca for any of those more personal inquiries that you have. We are recording today, so if you have a friend who might be interested in watching this session who couldn't be here live, you're welcome to direct them to our website where our recordings live. We also have a post-webinar survey that's going to pop up on your screen after the webinar, and that gives you the opportunity to share any feedback that you have with us. We appreciate your feedback, and anything that you're willing to share with us helps us to develop our programming further. So please take a few moments at the end to do that. And last but not least, before we get to our speakers today, I'd like to take a moment to highlight an upcoming special project that we're working on here. We have a premiere happening on World Right to Die Day. That's November 2nd. In My Own Time is a documentary that looks at what it means to die on one's own terms. Using firsthand accounts from people across Canada, this film will offer perspectives on medical assistance in dying, less commonly seen in media reports, and present an opportunity to educate people on end-of-life choice in Canada. So that will be on November 2nd at 7 p.m. Eastern Time, and we'll be hosting a premiere of this film at Scotiabank Theatre in downtown Toronto. If you're not in the GTA but you'd like to see the film, do follow us on social media because we will be announcing other events taking place throughout November and other screenings of this film. And we hope you can join us. And now we're ready to get started with our content for today and introduce our lovely speakers. We have with us Amber Hultink, who is a commander with the County of Renfrew Paramedic Service. Her current portfolio is community programs, which includes the Community Paramedic program. Amber has been involved with community paramedicine since 2008 and is passionate about equitable access to patient-centered care. In 2018 and 2019, Amber was seconded to the Canadian Foundation for Healthcare Improvement as a paramedic improvement lead to work on a pan-Canadian project to implement paramedics providing palliative care in 7 jurisdictions across Canada. Thank you, Amber, for being with us today. Heather Quinn graduated from Humber College in 1994 and became an advanced care paramedic in 2000 with Halton Region Paramedic Services. She moved to community paramedicine when the pandemic hit by joining the mobile COVID-19 vaccination team. She has been with the Community Paramedic program for 2 years, visiting vulnerable and at-risk seniors in their homes to prevent hospitalization and ER visits. She spends her free time sailing competitively and mountain biking. And thank you, Heather, for joining us today. I will now pass it over to Kat, who's going to get us started with the interview.
Hello, everyone, and thank you so much for joining us. Thank you for the warm welcome, Kelsey. And we will begin our interview questions. So for many, the role of a paramedic is understood to be that of a responder in times of a medical emergency or of crisis. Can you provide a broader definition of a paramedic services and training? That can be you, Amber, or Heather, whoever would like to begin.
Sure, I'll take a stab at it first. So paramedics have long been responding to all types of calls in the communities that we serve. Not all of these calls, however, are true emergencies. They are obviously emergencies and a crisis for the patients that we serve, but often these patients can be better served with a different approach than taking them all to the hospital, which is our traditional model. There was a concept by our chief to implement community paramedicine model, which is a proactive model, kind of takes a public health approach of preventative health education, health promotion activities that are focused to the needs of residents of our communities to try and keep them well and affect their disease trajectory to hopefully alleviate some pressures on our 911 system and also our emergency departments. So goals of our program are obviously to serve the needs of the community while reducing 911 calls, trying to reduce avoidable emergency department visits and hospital stays through our preventative and responsive care, such as things like remote patient monitoring, mitigating, as I said, illness or disease trajectories, and supporting the patients and residents by ultimately trying to increase their quality of life, and minimizing the wait list growth and duration for long-term care by trying to provide alternatives to folks in the community to wrap care around them and keep them where most people want to be, which is at home. And our palliative care program helps with that continuum, right from acute or chronic illness, right up to the inclusion of end-of-life care.
Okay, thank you so much for that. It sounds like there's more of a holistic approach that's happening now. So thank you for that. Heather, do you have any insight?
I completely agree with Amber, and I think the one thing that I'm going to learn from Amber is that the Renfrew model has been looked at worldwide as being one of the most advanced and forward-thinking models. And places from all over the world have come to Renfrew to see how they are doing their program. And so we're playing catch up as well, but we are learning a great deal from Renfrew, as can the rest of Canada and the world on their that model of preventative medicine, getting to the patient before they meet a crisis point and need 911, and almost like a European preventative proactive model. That's the way healthcare needs to be going towards.
Okay, thank you so much for that. Heather, this question is for you again. You had originally joined the Halton Region's Community Paramedic program during the pandemic. Can you tell us about your current role and what drove you to make the change from emergency response?
I think what happened was, and it sort of hit us all of a sudden back in January of 2020, when we were first getting the waves and the news that there was something coming from overseas, this virus. And immediately Halton Region launched in March a program where we were going ahead and doing mobile vaccinations into all of our seniors' homes, our long-term care homes. And I was part of that mobile vaccine team. And it felt really important to be sort of taking this role of stand and fight against this virus that was coming that we didn't know a lot about. And out of that mobile vaccine team came the idea and the impetus to create and continue this in-home care of treating clients in their home, not having them to go into 911 system and in the emergency departments. And unfortunately, we were getting a huge backlog. So this program got started, recognizing our vulnerable and our at-risk seniors, keeping them at home, where many of them were too afraid to leave and weren't even going into hospitals when they needed it. And so that was a really, really great program and a new idea for all of us. And for me, after 29 years of doing emergency care and emergency response, I thoroughly enjoyed that role. And I think that I did a lot of good, but it was time for a change to see if we could address this in a different way, after sort of the same model that was kind of not working very well. And so it was a great thing to be part of the launch and part of the groundbreaking process of this new world of care that we're entering.
Amazing. It sounds like this was a long time coming and something that really needed to be implemented. So thank you for that. Heather shared some examples of during the pandemic and wanting to stay home rather than going to the hospital. Amber, can you share with us some other specific examples of times where care within the home would take place rather than an ER visit?
Yeah, for sure. So it's something that we're trying to model more and more. As Heather alluded to, the way emergency medicine was designed for is for those high acuity events. But in Renfrew County, we have a lacking, probably not just Renfrew County, all of Canada, lacking in primary care. And so Renfrew County is the largest geographical county in the province of Ontario. We have about 100 or 110,000 people spread out. And we have some factors around socioeconomic status that are disadvantaging the folks that live here. We also have, we have a lower median income and higher level of comorbidities than the Ontario average. And about 30% of our population is unattached to primary care. So a couple of models that we implemented during COVID, COVID was definitely the catalyst to this change, was our virtual triage and assessment center, which is online, either through video or through telephone, where patients who have a primary care medical concern, so not an emergency, are able to call through, speak with a medical receptionist who will connect them with either a nurse practitioner or a family physician. That provider then calls the patient back, does a virtual assessment, and depending on the patient's needs, the referral can also then be sent to a community paramedic to go into the home and provide an in-home assessment. So sometimes somebody calls in, the physician or nurse practitioner would like vital signs, would like an ECG, perhaps would like some blood work or urinalysis. Those are all things that a referral can be sent to the community paramedic for those that are unable to get to those services otherwise. And during the pandemic, we did have a lot of homebound patients that had difficulty getting out due to lack of services available. So in Renfrew County, there's no public transportation, and a lot of services were shut down because of the risk of the pandemic. So community paramedics filled that gap by going into the homes, providing these assessments. We would initiate treatment when appropriate, and then loop back with the primary care provider to develop a treatment plan and hopefully keep most of those patients out of the hospital if possible. We did a lot of work with those that were COVID positive with our remote patient monitoring program. So we were able to remotely monitor their vital signs, so we could drop off equipment at their home. They could check their oxygen level, their blood pressure, their heart rate, their temperature. During the initial acute phases of the COVID viral infection. And we were able to catch patients that were starting to have a negative decline in their disease. And we were able to then intercept that sooner and hopefully try and manage those symptoms more appropriately, all while keeping the patient in the home. We also implemented a palliative care program. The early days of the pandemic, we had very sobering conversations around, based off the European numbers that Heather was speaking about. It was quite scary, to be frank, that we were anticipating thousands of COVID positives at once and potentially hundreds of those would be dying. And so there was a lot of question for a setting like Renfrew County. We have 5 community-based hospitals. One of our larger hospitals had 13 beds for COVID positive patients. So where do you put these patients and how do you best manage them and support them? So we worked very closely and collaboratively with our local partners in Renfrew County to develop a palliative care program. And that is continuing to run to this day. And it's been quite successful in helping manage patients who are receiving a palliative approach to care to align with their goals of care, which is often staying at home. And we supplement the care team and help fill gaps to help keep those folks out of the emergency department.
Thank you so much for that. And as you mentioned, you're filling the gaps that are really very much needed right now. So thank you for that. This is a question for Heather. What do your day-to-day operations look like as a community paramedic? And a sub question to that, do you have multiple patients or clients that you serve each day? and what kind of care does that really look like?
So a day is always unique. It's a what's going to come into the office and what's going to be there in the morning when we arrive. We're actually a 24/7 service. We're available 24/7 to all of our clients who have signed up for our program. The hope is that they phone us rather than phoning 911, and we'll either come and visit them and determine, is this something that we can treat at home through we have a medical director, Dr. Gina Agarwal, who is wonderful. She's been a staple of our program, and we can either work under her standing orders or get antibiotics from her for things like respiratory infections or urinary tract infections, and that patient can stay at home. So a typical day is arriving, we'll do initial assessments and meet new clients. That usually takes about an hour. We find out your medical history, your medications, who your family doctor is, and just generally learn a little bit about the family and the patient and get to know you, and for them to get to know us. Once you're enrolled in the program, we do our best to try and put hands on and eyes on our clients at least once a month, and follow up with phone calls, just checking in. And of course, they can call at any time, day or night, when they have concerns or medical issues, whether it's pain or swollen ankles or any kind of a complaint that they aren't sure where they need to go next. We'll come out and visit and determine whether we can treat them at home or whether this is a necessary 911 call. And so right now we are just about to sign our 1,000th patient into our program. It's growing exponentially. This need is far more than we ever imagined, and we're going to be having to take on more staff. And we are thrilled to hear that we just had a new contract, and we have the funding for 3 more years for this program. So it's only going to grow and only going to get bigger. And so every day is something new. It's a new challenge, and it's a little different from being on the ambulance where you just pick them up, take them to the hospital. Now we do everything we can to stay at home, which is a huge change from the way we used to think for decades.
Right, and that's amazing. So folks have something to look forward to. I think that follow-up is really needed for a lot of folks. So thank you. This question's for Amber. During your secondment, you were asked to assist with an initiative to implement palliative care paramedicine programs in 7 new jurisdictions across the country. What is the goal of this initiative, and how can palliative paramedicine achieve this? And a sub-question to that, what are some of the common misunderstandings that people have about palliative care?
Yeah, thanks for the question. So in 2018, 2019, I was on a secondment to the Canadian Foundation for Healthcare Improvement, CFHI, which is not a radio station, but they're now known as Healthcare Excellence Canada. And they had partnered with the Canadian Partnership Against Cancer to put out a call for innovations in healthcare. And so the province of Alberta had a fantastic program, as did Nova Scotia, where they had pioneered, frankly, paramedics providing palliative care in those jurisdictions. And those were the innovation sites that we were able to leverage and get best practices and lessons learned from. There was then a call for proposals that was put out to the rest of the country. And there was 7 jurisdictions across Canada that were the successful applicants to receive some funding and to be able to spread and scale this initiative in a meaningful way. So I spent a year there sort of as a paramedic lead, working with the team at CFHI to help develop and implement these programs. It was quite interesting and eye-opening just how healthcare is across the country. And it's certainly not equitable everywhere. And each jurisdiction has their unique challenges. And I think that that's one of the benefits of community paramedicine is we're able to be responsive and nimble and respond to the needs that are unique to our community. In terms of paramedics involved in palliative care, the intention was never to duplicate service. It was just to fill the gap. Certainly in the experience of Renfrew County, we have a large county, and sometimes the nurse is going to be delayed just based off drive time and weather for an hour or 2 to get to the patient. 911 is the ultimate safety net of the healthcare system. When all else fails, folks will call 911. When they panic, they will call 911. So providing our community paramedics with additional education and supports and medication around how do we best support these patients? How do we integrate with the community-based care team so we're not duplicating services, but we're working as a member of that team to help align our care with the patient's goals of care. So everything that we do as community paramedics is trying to be an extension of primary care. The traditional role of paramedics, we're well versed in emergency care, and we can probably run a resuscitation in our sleep. But we're definitely trying to provide care that the patient needs in a time when they need it, in a place where they want it. So it's been quite successful. In terms of some misconceptions about palliative care, I'm certainly not an expert in palliative care, but I would think in my experience, we've seen people are sometimes just afraid of the word palliative, that it means that they've given up, that it means death is imminent. We're trying to educate our staff on more appropriate terms, such as providing a palliative approach to care, and that the evidence supports that an earlier intervention of palliative care can actually sometimes prolong life and increase certainly the comfort of those patients in their final months, weeks, and days. It is, at first glance, I think, a little bit obscure for some people to have paramedics, engaged in palliative care, because our traditional role is emergency medicine and taking folks to the hospital and providing that level of service in acute and high acuity patients. But we're actually really well positioned to be able to respond. Our service is also 24/7. And it's just providing, through our community paramedic line, an alternative to the 911 system. So in Renfrew County, there are no walk-in clinics. We just have emergency departments. And so if people had a healthcare concern, they would often present to the emergency department, because 30% again don't have access to primary care. That has now been blunted with the introduction of our virtual triage and assessment center. And we've also had a positive impact on our 911 calls with our community paramedic program, to be able to offer patients an alternative to the 911 system and emergency department.
I think Amber makes a really good point there, that I think palliative care is a word that is misunderstood. Certainly palliative care is about end of life, but you could be a palliative care patient for years if you have a chronic disease that will not improve. So palliative care does not mean end of life necessarily. It is one meaning, but it also means a chronic disease that will not improve. And so some people can be considered palliative for, as Amber said, for months to years. And it's about good treatment and prolonging and making sure that time that's available is as positive as it can, and as pain-free and as comfortable as possible. And Renfrew is doing the same thing. Hultink has just started a new program in September. We'll be offering palliative care at home as well, with symptom management. And that's going to be something that's really important at 3 a.m. when, unfortunately, you don't have maybe you can't get a hold of the palliative care nurse. They're busy, they're overwhelmed, just as all healthcare is. And our primary and advanced care paramedics can step in with some symptom management and make that person more comfortable, and do something called treat and refer. So the patient will not have to go to the hospital. The symptoms will be managed at home, and they can remain at home. And this is a wonderful thing that we're all working towards.
Okay, I love how you both put it. I think there is a stigma when it comes to the word palliative, especially palliative care in general, and being able to help folks within their home and not having to rely on 911 calls and the ER is great. So thank you both for that. This next question is directed to Heather. Do you have any observations about grief based on your experiences? Is grief something that you too experienced as you cared for people in your roles?
Certainly, the community paramedic gives you a completely different perspective on your patient, because this isn't just somebody who I've met in an emergency response dynamic. This is somebody who I've been in their home. I've petted their dog. I've fed their cat. I've met their entire family, and I sometimes feel like I'm a part of their family as well. And they're with us sometimes for months and sometimes years. And I think for me, one of my hardest lessons was one of our very, very favorite clients. We're not supposed to have favorites, but this lady was just such a character, and we just loved her. And unfortunately, she had respiratory issues, COPD, was on home oxygen, and contracted COVID. And I remember that we visited her on the last time that we got to see her. We went up to the ICU, and of course, at that time, you weren't allowed to go in. We were gowned and gloved, and we were waving at her through the window. And we had provided with her, we carry these little dogs. They were little stuffed animals. They look like little St. Bernards, and we call them Siren, and we give them to our children, our pediatric patients, or our seniors. And we had given her our Siren doll, and so we could see her through the window, and she turned to us and she waved, and she got the little Siren doll's arm and got him to wave to us as well. And then she gave us a big thumbs up, and we said goodbye to her. And unfortunately, 2 days later, she passed away. And that was a huge upset for us. It was like we had lost one of our favorite family members. And so for our team, that was a bit of a devastating loss, that, you know, somebody who we felt like we knew as a family member was gone now. So that was my first experience of what this new role was going to mean from an emotional and a mental health point of view, and that it means that there's going to have to be a little bit of a change in my way of coping with that. And so it is going to be a different lesson to learn, but it's a good lesson to learn. So.
Right. I'm so sorry to hear about that loss. It can be difficult when you're dealing with people on a daily basis or a weekly basis, and to see them go. They're just like family, right? Like you said it best. So we understand how that can be difficult. Same question to you, Amber. Is grief something you too experienced as you cared for people in your roles?
Yeah, I think grief is something that everyone experiences. Generally, our traditional role of a 911 paramedic, we do speak about, you know, the impact that can have on you as a first responder and some of the traumatic events that we encounter. There has been a lot of discussion and a shift with anyone who is a regular community paramedic. And that you do develop these relationships with patients. Usually we see them for, 20 minutes, an hour, and then we drop them off at the hospital. And we often don't hear about what happens to them. And that's usually the end of our interaction. It's very brief on the 911 side. Whereas you have these more long-standing relationships, and you are welcomed into their home. And, certainly we're welcomed into people's homes on the 911 side, but to really get to know them and understand their complexities, their pressures, and how we can support that and integrate and refer them to other services in the community, you do build that relationship. Certainly, some patients prefer certain community paramedics that they're used to, and so that's been a point that we've had to try to address as well, that it can't always be Heather that's going to see Catherine. We need to provide some healthy boundaries and also continuity of care to the patients. We have actually had to have meetings with some community paramedics to check in whenever they are very invested with some patients, and depending on the complexities of those situations, it's not always involving end of life. There can be some challenging social factors that some of these community paramedics are trying to help the patient navigate, and that can be taxing. So I think we have a great peer support program in our county. We have access to other supports through the service and through our corporation, and I think peer-to-peer informally, the conversations are had on a pretty regular basis. We do weekly case studies as a group, which I think also allows us an opportunity to identify any challenging cases that we may need to discuss as a group. And it is a multidisciplinary team that we're having these discussions with. So there's primary care provider and home care representatives as well. The role of a community paramedic is definitely that, being team-based. When we partner, we've done a lot of great work with our hospital partners, with those at the hospices, with home and community care support services, to try and establish those relationships and communication lines. So sometimes, whenever we do have a patient who's died and perhaps it was expected. We have also held debriefs with the broader care team. So with our paramedics that have been intimately involved, and also perhaps the home care nurses, the care coordinator, the physician. So it is an opportunity as well to come together, and it's used as a learning opportunity for sure, but there's also a sense of community as well for the paramedics. So I think everyone does experience grief. The role of a community paramedic has a different spin on it than our traditional role, but I think we're all adapting quite well to respond to that.
Okay, thank you. And I think you said it best. Debriefs are so important, especially when you're working with any kind of public person, like whether that be in their home, in a hospital, whether that be a visit to the clinic. It's so important to take care of our mental health as well, just as much as it's important to take care of theirs. So thank you for that. This one, Amber, goes to you. You've been working in community paramedicine for 15 years now. What has been the effect of this program for Renfrew County?
Yeah, it's come a long way. The early days in 2008, when I started, we were partnered with a local long-term care home. And the intent of that program was to target the top 32 people on the wait list. And this was in Deep River, Ontario. Top 32 people on the wait list for long-term care, and try to wrap care around those patients. So it was a partnership, as I said, with the long-term care home, and we had PSW support. We were the medical support. There was dietitian support. There was things like housekeeping and yard work support. And the goal was just to try and support these 32 people that were on the wait list for long-term care, support them in their home so that they can live there longer and more safely. And we actually did publish on that. We saw some great success. Most patients were actually able to stay at home for end of life and never having to go into long-term care. Our program in the mid 2010, so probably around 2015, we did expand, and now we're just advanced care paramedics that are operating as community paramedics, and we have a dual role where we'll also provide advanced care paramedic backup or first response in the community. And so we have more paramedics in the community that are available to respond to those high acuity calls, or also to provide an extra set of hands for some of these really complex calls and patients that our 911 calls are responding to. And since that time, we've received additional funding from the provincial government for community paramedicine and long-term care. So again, it's kind of back to our roots of the Deep River days, where we're targeting patients on the long-term care wait list. That is now rolled out provincially. So I think every paramedic service in the province, or almost every paramedic service in the province, now has CPLTC funding. And it's for anyone who's on the long-term care wait list, eligible to be on the long-term care wait list, or soon to be eligible for the long-term care wait list. And the program is to help keep them at home with appropriate support, and trying to decrease the number of individuals who actually require placement in long-term care. So it is a coordinated effort between primary care, home and community care support services, nursing agencies, and community paramedics to wrap that care around patients in their preferred place, which is often home. So we've seen great progression of community paramedicine since 2008. When I started, there was one of us on in Deep River, and today we have anywhere from 6 to 12 community paramedics on throughout the county, which is a fantastic resource from a 911 perspective, to have an additional 6 to 12 paramedics in the communities. We do operate sort of in a zone-based model. And so paramedics, if they're working in the Eganville area, they know sort of all the events that are going on in Eganville. They are connected with the primary care providers in that area. They can support school initiatives in that area, and also 911 response. So it's a great model that's tailored to each unique community, because we do have differences even within Renfrew County. that are community based. So community paramedicine, again, is not there to duplicate. It's there to, work as part of the greater care team and wrap care around these patients to ultimately improve the quality of their life.
Okay, thank you so much for all that insight.
Mm-hmm.
You both have experience helping people through a health crisis. Do you have any takeaways related to advanced care planning and thinking about and communicating one's medical priorities, beliefs, and values? Everyone wants to go first.
Yeah, I think one of the things that I sort of approach head on during an initial interview with one of our clients that we're about to decide to take on as a client is I do ask them, have you ever had the discussion with your spouse or with your family in regards to what happens in the event that your heart stops or that you are no longer breathing? Did you want paramedics to come and do CPR and put a tube down your throat to help you breathe and give you those, cardiac medications? And I always want to know what the thinking is there, and sort of establish that at the very beginning, because I think first of all, it's really important to always have the patient's wishes in mind and know about that. So that's one thing that I think is really important to know. And even if they've never had that conversation before, hopefully the question that I ask will start the conversation with their family. Maybe that evening when they're, talking with their family about this meeting they had with this paramedic, that this conversation came up, and maybe this is something they need to discuss and iron out. Because as an emergency first responder, the number of times that I responded to cardiac arrest in the home of family members who, even couples who had been married for 50 and 55 years, we would come to them. One spouse was, not breathing and didn't have a pulse. And I would say, have you ever had the discussion where, what would you like us to do? Because the wishes of the family are always paramount. And so many of them had never had that discussion in 50 to 55 years of marriage. It was nothing that they had ever spoken about. And I think, once again, there's that stigma of talking about death that we need to remove and make it a more natural and comfortable discussion, and something that family members are aware of and will honor at the time, even though it can sometimes be a time of panic. But the time to have that discussion is not during the emergency. It is to have that discussion when it's quiet, when it is emotions are not running high, and you've had time to think about that decision, and make that information known to your family. It is so important that they're aware of what your wishes are, and it's clear and paramount to them that they know exactly what you want. So in the event of that, if it's a dramatic event where it's a sudden death in the home, that they know and they're very clear as to what the family members want and what that loved one wants, and we will honor that. Then the times of running a cardiac arrest and running to the hospital where, unfortunately, for the most part, and the statistics bear this out, there is not a good outcome. We do not do well with cardiac arrest in the home as much as we try and do everything we can. The statistics just aren't there. And so now we're trying to move towards a cardiac arrest where everything that a hospital will offer and an emergency department will offer is in the home. We will provide that care in the home. And in the end, we will, with consultation with the family, we will pronounce that patient, and that patient will stay home. And I think that that's statistically has shown to be a better outcome for grief and for recovery and for just the whole mental health way of coping with it afterwards. It's been shown to be much more beneficial to families in the long run. So that's, I think, where we're going. And I think it's a really, really good place. But it's a conversation that everyone, all these people who are listening to this webinar, have that discussion with your family. Sit down at a quiet time when, as I said, when emotions aren't running high, and discuss this, and make it clear, this is what I want. This is my needs. This is my request. And have that written down and make sure that everybody is well aware of that. Something else that you can do is go to your family doctor and have a do not resuscitate form filled out, and a doctor or a nurse can sign that, and paramedics in the home, emergency paramedics, will honor that do not resuscitate, and we will not commence resuscitation, which can be very almost violent and very painful to watch. It's not a pleasant thing to be a part of and to watch. But having that documentation at home will ensure that we honor those wishes, and we will be very respectful of those wishes.
Thank you for that. And I think that we all at Dying with Dignity Canada agree that we should all have those hard conversations, but very much needed conversations about our end of life and our wishes that we want, right? So thank you for that. Amber, do you have any insight on that about advanced care planning, thinking about and communicating your medical priorities, beliefs, values?
Yeah, I would echo everything that Heather said. I think it's paramount that folks are having those discussions early, because it's very difficult whenever the paramedics are at your home for a cardiac arrest to be engaging in those conversations, because we have our protocols to follow and we have what we're trained to do, and trying to align our care with the patient's goals of care is always our goal. I think the conversations are probably, started, or seeds are planted by lots of different healthcare providers, by, your home care team, by your primary care team, perhaps by your specialist. Sometimes paramedics, the uniform just is sometimes a powerful thing, and paramedics are one of the most trusted professionals that we have in Canada. And sometimes we can just bring it up, even though it's been brought up a dozen times before. Sometimes patients have a different response to us bringing it up, or sometimes they even ask, well, what does it look like? And what do you mean by a do not resuscitate order? And what do you mean by CPR and breathing tubes? And we can describe that to them. And sometimes they say, oh, no, I don't want that. And as Heather said, then it's, we can direct them and say, probably worthwhile to have the discussion with those, your family and friends, those that are around you. They're going to be the ones with you and calling for help. So I just think having, early discussions, normalizing the discussions, is just really key to us being able to align our care with what the patient ultimately wants.
Thank you so much for that. Okay, I think we have one more question. So this might be hard to come up with one, but what is your greatest lesson that you've learned in your career so far? If you had to choose one, what would it be? Either of you, whoever wants to go first.
I think I had a kind of a unique experience, and I happened to be mountain biking with some friends one night, and one of our riders ended up having a sudden cardiac arrest. And so here I am now dealing with a cardiac arrest. I'm out in the field. I have no equipment. I have no I have nothing. And I'm suddenly on this side of what I would describe where the family is. I am on the outside of this resuscitation watching it. One of the things that I did learn about that is that you have to be so cognizant of what you say and your actions, but mostly with what you say when we are dealing with patients and when we are talking around patients. And I'm just as guilty of it, where, maybe our family's emergency that they're dealing with, it's not an emergency in our minds because we're equipped to deal with it. So an emergency only exists when you're not equipped to deal with it, but we are. And sometimes we may not be as empathetic or as sympathetic as we should be. And being in the background of watching this resuscitation and hearing conversations going on, it made me realize that everything I say, every action that I have, everything that I do when family members or the public is watching me, it may not be my actions that they remember, but they always will remember how I made them feel. And it's so important that I make those people around the family and the family member and the client and the patient, I need them to know that I respect them, that I know that their emergency is important, and I'm dealing with it with the best of my knowledge and the best of my abilities. And it is my emergency as well as theirs. And I want them to take away that no matter what the outcome was, that paramedic listened to me. They spoke with me with respect, and they listened, and they took my concerns to heart. And I will always make sure that I act professionally and responsibly and calmly when I am on those emergency situations, having been on the outside looking in. It was a great lesson for me to learn, and it's something that I try and teach a lot of my new staff and a lot of the people who are coming, that make sure that, you know, that you are always at the top of your game. You are professional, you are courteous, you are respectful. That's what people are going to remember. And they're going to remember that for the rest of their lives, because this is a dramatic and life-changing event for them in some cases. So make that event a positive one as best you can.
Right. It's just as easy to think about that negative experience that you experience with somebody just as much as that positive one. So I think
People never
that's
forget that negative experience. Unfortunately,
Exactly.
they never forget that negative experience.
Right. So that's a great lesson. So thank you so much for sharing. Amber, what is your greatest lesson that you've learned in your career so far?
Yeah, it's been a humbling career, and we do get invited into people's homes and lives during, as Heather said, their emergency and their time of crisis. Whenever we go through our education and training, it's very much focused on, you know, diseases and body systems and patients. But probably the biggest lesson that I've learned is everyone has a story. And I think we often get caught up in our protocols and get caught up in what we're supposed to do in that moment, that you don't take the time to get to know that patient on a more personal level and really hear what their story is. And I think that comes with time. I think most paramedics, as they progress through their career, can start to find the story with each patient, as opposed to the palliative patient or the COPD patient. So yeah, it's just taking the time and asking a few extra questions, because it's often also easy for us to make some assumptions whenever we work in healthcare, and we have, as I said, our general guidelines and protocols on how we're going to be responding to the patient's needs and our assessments. But it's really trying to crack that a little bit and bring out the human element. I think that really is key to providing really great care.
Yeah,
Right,
we lost that with COVID,
yeah.
didn't we? We lost the human touch, I think, with COVID. Unfortunately, you know, the time of holding hands and things like that, and comforting people, we kind of lost that a little bit. I hope we're moving back towards that. It's so important.
Absolutely.
Right. I hope so too. And seeing a person for a person and not their disorder, their disease, or whatever may be hindering them in some way, right? So thank you so much for that. So that is the end of our formal questions. And now we have our audience questions, and we have quite a few. We have about 10, 12 minutes left. So let's see how many we can get through. Okay. So the first one, maybe one of you can answer a question each, so we can try to get us through as many as we can possible. So the first one is, how does one access these programs instead of calling 911? Can you tell us more about enrollment?
Amber, I'm actually interested to hear how the enrollment process takes place with yours. Our referrals, for the most part, come from our emergency 911 crews, who will identify an at-risk or vulnerable senior that they feel could benefit from our program. So that's a big part. We also have home and community care coordinators who will refer. Family doctors can refer. Actually, anybody in the public can refer to our program. And it's just a simple phone call. We will take down the information, the things that you're concerned about, where you see maybe some care is lacking and desperately needed. And then our scheduling agent will schedule a meeting, and we'll start the process. And we generally try and get those some kind of contact within 24 to 48 hours, and hopefully a meeting within 2 weeks.
Yeah, so we're similar. We'll take referrals pretty much from anyone that has a concern. We work closely with home and community care support services, primary care, hospital discharge planners, and our 911 paramedics as well. In terms of how to refer, so through home care, we do use their HPG, so the Health Portal Gateway, I believe it's called. But others can refer through CareDove, which is an electronic referral, and we just ask for some basic information. And obviously, if you don't have access to that, you can call our 1-800 number, which is answered 24/7. And that's available on our website. We've done a lot of outreach with health fairs, with seniors, senior centers in the community. And again, those community paramedics working in their zone have done a lot of outreach with the community-based organizations, able to get the word out. We do have some pamphlets and stuff that are floating around as well. I think in the early days, our chief went on CTV News and put our phone number there, and we've received a lot of phone calls. But I feel like we're well established now that most people know how to get a hold of us.
Okay, thank you so much. Amber, this one is directed to you.
Sure.
Amber, you mentioned a palliative approach to care. Can you share with us what that means?
Oh, yeah, I will try. Again, I'm not an expert in palliative care,
No
but
worries,
it is an approach to care that is aligning everything that we do with the patient's goals of care. And so what that means is having a conversation with the patient and what are their wishes and what is their biggest concern right now, and how can we help support them and manage their symptoms to ultimately improve their quality of life. We understand that a palliative approach to care, we're not going to cure the disease. We're probably not going to reverse it in any capacity, but we may be able to make the patient a lot more comfortable, or perhaps even blunt that disease progression a little bit. So it's providing that holistic approach to care. It's not just looking at the patient from a medical standpoint, but it's looking at the patient as a whole person, and really trying to meet all of their needs as best we can.
Thank you so much. Very well said. Okay, let's see. What has been the reception from fellow paramedics and healthcare providers with these new paramedicine programs? Have you experienced any pushback or concerns?
I think for our emergency paramedics, initially when we first got off the ground, I think there was a little bit of misunderstanding and miscommunication as to what the role of a community paramedic was. But we've done a lot of education and a lot of, during our continuing medical education sessions, we've tried to emphasize exactly what the program is about so that they're referring the right people to us. And to be honest with you, the response has been absolutely overwhelming. The 911 paramedics are absolutely thrilled that we're listening to them and that we're responding and answering their concerns with, what we call, and it's not a great term, but a frequent flyer. And that's somebody who is using the 911 system over and over and over again because they are not getting the care and the response that they need. So those frequent flyers are very much part of our program now, and the whole goal is to try and alleviate them from using the 911 system and using our program instead and calling us instead of 911. So for our emergency responders, they are not seeing patients that they may see 2 or 3 times in a set of their working set. They're not now seeing them. They're not seeing them for months. And we're getting, we even get them sort of giving us a call going, what happened to that person? We're not seeing them anymore. Are they okay? And we're just making it clear to them that, no, we're taking good care of them now at home, and they're no longer, needing the 911 system the way that they used to, because the 911 system is always the fail-safe and always the last resort and the backup that anybody can access. And hopefully we can, through our community paramedic program, make that maybe not the last resort. Maybe we're that first rung before we have to go to 911. So our emergency paramedics are thrilled with the program. They love it.
Thank you so much. Amber?
Yeah, I think if you've never heard of what a community paramedic is at first, you're probably a little bit confused. We've been established here, as I said, formally since 2008. I think we have had some pushbacks from some other organizations that perhaps didn't fully understand what we were trying to accomplish. And that was more in the beginning. There was concern about duplication of service and scope creep and roles being confused. But I think we've done a lot of work with our partners in the community and all the different organizations to establish, this is the role of a community paramedic, and this is how we can work with you. But ultimately, we're just there to help support these patients that usually have been ending up in the 911 system. So obviously there's a need that has been unmet. And so we're often, again, well positioned to be able to see the patient in that moment of crisis for them, see them in their environment. Sometimes these patients refuse to go to the hospital, and so they never actually do get perhaps a full referral or geriatric assessment, for example. They may not get referrals to perhaps home and community care because they're refusing transport to hospital. So it's providing our staff with another option for follow-up, so that again we're meeting the needs of these patients, and sometimes that is just linking them up with other services and resources that they just weren't even aware of. So I think initially there was a bit of pushback of what are you, and I thought you were ambulance drivers, right? And it's like, no, paramedics are, well-trained healthcare professionals, and we're happy to support patients in our community that are utilizing the 911 system and trying to support them in a more effective way.
Okay, thank you so much. Just keeping the time in mind, we're going to do one last question, and then a little bit more information for a couple folks that may have missed it in the beginning. So the last question is, can you talk more about CPR in older persons? I've read a few articles lately that say it can do more harm than good and not even save lives. So maybe Heather, you spoke a little bit about CPR a little bit earlier, so maybe you can touch on this.
Okay, so CPR will never cause more harm than good. That's a fallacy. Good CPR is I think of it as sort of as it's a spare tire to get you to advanced care. And what that CPR is doing is pumping blood and oxygenating the brain until life-saving care, paramedics, firefighters, and primary care and emergency care can get there. So you can never hurt anybody, and you can never harm anybody by doing CPR. It is the first chain of our our chain of survival. CPR is the first link. So never ever worry about hurting somebody by doing that. You will not. Keep in mind that when we are doing CPR, this person has no pulse and this person is not breathing on their own. So this essentially is a clinically dead patient. You cannot harm somebody who is clinically dead. You can only do good. Now, admittedly, the statistics do bear out the fact that in an at-home cardiac arrest, especially if there are comorbidities such as diabetes and heart disease, our statistics are not good. I mean, but we do have, depending on how fast that defibrillator gets there, the quality of CPR, the defibrillator, and advanced care, we do have numbers in the 7 to 9% of getting a pulse back. So please don't ever think that you're doing the wrong thing. You're not. Activate 911 and start CPR right away. That is that patient's best chance of some kind of a resuscitation. And obviously, the faster that happens, the better the outcome. But statistically, we have to keep in mind that we are sometimes dealing with a heart that is not healthy, lungs that are not healthy, organs that are not healthy, and a lack of oxygen only does those organs. It doesn't do them any benefit. So we do work as hard as we can. We will do everything we can, but the reality and the statistics are out there that that CPR in the home is statistically shows somewhat of a grim outcome.
Okay, thank you so much for that. And our last question is for the audience members that may have missed it in the beginning. Could you just name your program once more? And if you have a website or social media page, that way anybody can access a little bit more information, if you could just say it out loud.
Sure. So for Renfrew, we have the Community Paramedic Response Unit, so CPRU, and we have a website that is www.renfrewparamedics.ca. You can find our 1-800 number there and more information.
Okay, thank you.
We are working very hard, and we are a little behind. We are working on a website and some more information of our online presence. But right now, our email address is communityparamedics@hulton.ca, and our 24-hour number is 905-825-1202, extension 1, and that will be picked up by the cell phone that our community paramedics carry, and we're always available. You can also get access for Hulton Region people who live in the Hulton region through 311 as well. They can direct your call to our office as well.
Okay, thank you so much. So with that, unfortunately, we're out of time for today. Thank you so much, Heather and Amber, for joining us today and all of your insights. And webinars like this one and all of our other compassionate services are provided free of charge to Canadians navigating end of life, their loved ones, and their healthcare providers. To enable us to continue providing these services, please consider making a charitable donation. We will put the link in the chat in case anyone would like to donate. Thank you to our audience for joining us today, and have a pleasant afternoon. And once again, thank you so much, Amber and Heather, for joining us today. Thank you so much to our attendees. Take care.
Thank you, Chad.
Thank you.